these are my disclosures. And so 10 years ago, the PARPi study demonstrated the value of alterations in DNA repair genes to predict response to PARP inhibitors, to olaparib in this case. And it was quite clear from the beginning that most patients without those alterations will not respond to the PARP inhibitor. Although if we'll look at this image, there are a couple of patients without HRR alterations that qualified as a positive biomarker who actually responded to the treatment. But the proportion of patients was very small, and for that reason, all the development of PARP inhibitors with the different agents has only focused on patients with HRR defects. So up to now, we don't have data of PARP inhibitors in monotherapy for patients without those alterations. So, as I said, the studies focus on the group of patients with alterations in the homologous recombination repair pathway, which is the pathway most frequently altered in prostate cancer. But this is an heterogeneous group. So often we talk about HRR or this homologous recombination as a homogeneous group, but it is not. It includes several genes with different functions. So some of these genes sense the damage, other genes modulate the response, and others are actually the effectors, the ones that repair the damage. So depending on the function, the cells are able to overcome this deficit with other genes. So there will be other genes that will be able to assume the functions of the gene that is gone. And this results in different levels of homologous recombination deficiency. So in the upper figure, you see that if the BRCA genes are gone, you are going to have more homologous recombination deficiency that if other genes are lost, right? And this translates in different clinical impact. So if BRCA is gone, you see in the first bars, in the green ones, that the time to progression and the overall survival is significantly shorter than if other genes are lost, that is the second bar in yellow, or if the patients don't have any HRR alteration. So the implications are different. The HRR subgroup is heterogeneous. And we have also learned that this heterogeneity results in different sensitivity to PARP inhibitors. So the patients that benefit the most are those with BRCA alterations. It's very clear from these waterfall plots in two different studies. The first one is for PROfound. The second one is for the Triton study with rucaparib. And we've also learned that patients with other alterations such as ATM or TEC2, CDK12 do not seem to benefit as much as those with BRCA alteration. And you can see that less patients with these alterations respond to PARP inhibitors in monotherapy. And there's also another group of others that includes less frequent alterations who seem to respond to the PARP inhibitors. But what happens is that because these alterations are rare, we don't have enough information. Each study only includes a couple of those patients, and we need to pull data from different studies to actually get a strong evidence. These are data from the Triton 2 study, and it shows how, for patients with PALB2 alterations on the back of the graph, the response to PARP inhibitor is as good as for patients with BRCA2 alterations. So alterations in PALB2, which are very rare, sensitize tumors to PARP inhibitors almost as much as BRCA2. But other genes, such as FANK-A, don't seem to sensitize as much. So there is some granularity that we are learning. The PROfound study was the first phase 3 trial that we had with PARP inhibitors in prostate cancer, and it demonstrated that for patients who had already received an ARPi, an hormonal agent, and had HRR alterations, if they were included in cohort A because they had alterations in BRCA1, BRCA2, or ATM, treatment with olaparib was significantly superior to a second hormonal agent. Treatment with olaparib in these patients prolonged overall survival. But for those patients with other alterations that were included in cohort B, treatment with olaparib did not significantly improve overall survival. And finally, with the Triton3 study that included, again, patients who have progressed to a hormonal agent, who have alterations in BRCA1, BRCA2, or ATM, so the same patients that were included in cohort A of the PROfound study, we saw that treatment with rucaparib was superior not only to the hormonal agent, but also superior to docetaxel. This is something that we have never seen in prostate cancer. Nothing has beaten docetaxel. So for BRCA patients, a PARP inhibitor seems to be better than a taxane. But we don't see that for patients with ATM alteration. So there is a lot of granularity in the response to PARP inhibitors. So it seems that it's quite clear for patients, for PARP inhibitors in monotherapy. Patients with BRCA1 and BRCA2 clearly benefit. Patients with other HRR alterations, we are slowly learning the details of the sensitivity. And patients with ATM or CDK12 alterations don't seem to benefit from a PARP inhibitor in monotherapy. But the majority of our patients don't have HRR defect. What should we do with these patients? We now have evidence or data from 3 phase 3 trials, PROPEL, TALAPRO, and MAGNITUDE, that have explored the combination of a PARP inhibitor with an ARPi, with a hormonal agent. 2 of these studies, PROPEL and TALAPRO, have shown a benefit in time to radiographic progression from these combinations in unselected patients. The third study, the MAGNITUDE study, failed to show this benefit in patients without HRR alterations. But if we look to the details, we see that there is a clear hierarchy in the benefit from these combinations. These are data from the PROPEL study because it's the study that has already reported overall survival. Survival of TALAPRO-2 may be presented this year, not this year, 2025. We need to wait a little bit, but this is for the PROPEL. But I think it's very clear how patients with BRCA alterations are the ones that benefit the most, followed by patients with a spectrum of HRR alterations, and then patients without detectable HRR defects have a benefit in rPFS, but not in overall survival. So if we don't test our patients in an unselected population, the benefit will be somewhere in the middle between those with HRR defects and those without detectable HRR alterations. In PROPEL, in overall survival, there was a 7 months benefit in 7 months difference benefiting the combination, but that difference was not statistically significant, right? And for patients without this defect, we don't see a benefit in OS. The FDA, acknowledging this heterogeneity of the HRR subgroup, tried to make sense of all these studies and published this year a pool analysis of the different studies. In these studies, the genes that were included were different, but there were 6 genes that were included in all of them, and these are the ones that have been analyzed here, that were BRCA1, BRCA2, CDK12, PARPi2, ATM, and CHEK2. All the other genes were different in the different studies. So this analysis shows a very clear benefit for BRCA2. There is benefit for BRCA1 and for PARPi2, but the number of patients are small because these are rare alterations in prostate cancer. However, for PARPi2, there were 44 patients, and it's probably the largest series ever because it's so unusual. But if you come across a patient with a PARPi2 alteration, remember this analysis because I think it's worth for these patients. And the surprise was that for patients with CDK12 alteration, the combination of ARPIs and PARPIs result in rPFS and overall survival benefit. We don't see this benefit for PARP inhibitors in monotherapy, but we see it from the combination. And this is important because our patients with the CDK12 mutation have poor outcomes. They don't seem to respond very well to other therapies we currently have. Toxicities. The toxicities are aligned with the toxicities of PARP inhibitors in monotherapy, and the most frequent side effects are anemia, hematological toxicities, gastrointestinal toxicities, and fatigue. And we do not see a difference between in toxicity depending on HRR status. So it's the same for all our patients. So we need to balance the potential benefit and the potential toxicity to decide if we want to offer these treatments to someone without HRR alterations or without BRCA alterations. But we cannot deny that there is certain benefit for patients without HRR defects because we have seen this in PROPEL and in TALAPRO. Why do we see this benefit in these patients? Is the synergy between the ARPI and the PARPi? It could be. Is it because there are some HR deficiencies that we are not detecting because we are only analyzing the presence of mutations, but there could be many other ways that the cells lose the ability to repair DNA? It could be. Or it could be that there are other events unrelated to homologous recombination that sensitize cells to PARP inhibitors. It could be. So going back to the TOPARP study, I mentioned earlier that what we saw in this study is that the great majority of patients without alterations do not respond to PARP inhibitors in monotherapy. And this year, this study was published that investigated PARP inhibitors in patients with biochemical recurrence. And what they saw, it was unselected patients, right? So again, very clear benefit for patients with BRCA alterations, and represented in brown are patients without detectable HRR. And as you can see, the response, these are PSA responses. None of the patients without HRR defects achieve a PSA response as a 50% decrease in PSA levels, and some of them actually did not have any PSA response at all. So this is the data from PARPi monotherapy is the only data we currently have. So what could be driving these responses in patients without HRR defects? This is an analysis of the TALAPRO-2, that subgroup of patients without HRR defects, and they were trying to identify other candidate genes that could explain why these patients responded, or why we saw a benefit. So the candidates included the Tempurus ERG translocation that we have been discussing for years, the RB1 loss, and KRAS and MLL2 that were finally not pursued because they failed other statistical analysis. But for the Tempurus ERG, it's quite interesting because we have discussed this for many years, and what they saw here is that patients with this translocation do significantly worse than patients without the translocation when treated with enzalutamide alone, so 11 months versus 23 months. But when these patients receive also the PARP inhibitor, the rPFS was significantly longer, was more than double. So it could be a potential reason why these patients respond. And many years ago, over 10 years ago, there were already some papers suggesting an interaction between PARP1 and ERG, and that could explain the reason. But in the TOPARP-A study, they explore whether these alterations could or not predict response to PARP inhibitors, and they didn't see anything. So we have to wait and see. But this is just to illustrate that there are many things coming, trying to explain what happened with these patients. So just allow me to conclude with a reflection. So you asked me at the beginning if we should consider triplet therapy with a PARP inhibitor for all patients with mCRPC. And we discussed yesterday whether we should consider triplet therapy with chemotherapy for all patients with MHSPC. And it was clearly no. No, because there is toxicity, and we don't know which are the patients that benefit. And we said we need markers, we need biomarkers to identify who are the patients that are going to benefit from chemotherapy. Okay, we have biomarkers to identify who are the patients that benefit from the PARP inhibitor. So let's use them. And thank you for your